Good afternoon, everybody. Thank you very much for attending. There's just some announcements I have to go through as we are live on our council's YouTube channel, Hillingdon, London. So a warm welcome to everyone who's watching, and thank you to all of you for being here today. The information about the business to be considered is shown on the agenda, which there are copies in the room, and it's also accessible online under the live broadcast. For those of you hoping to speak today, could you please use your microphone and note that you will be filmed and any statements you make will be recorded and will be made public. At the end of the public meeting, when the board moves to discuss any confidential matters, the live broadcast on YouTube will be cut. And a reminder to anyone speaking today that your voice will only be audible online if the microphone is switched on. I do not believe we're expecting a fire drill, but if the alarm goes off, we follow the officers out to the fire exits and out to the building. And you may see on YouTube, those of you watching on YouTube, some people using their mobile and tablet devices. But could I ask that you switch off your mobile phone so that we don't hear them ringing? Thank you very much. That just means that we can now start the main agenda item, and the first agenda item is apologies for absence.
Chairman, we've had apologies from Vanessa Odlin. Unfortunately, we were unable to get a representative from CNWL today. We've also had apologies from Lynn Hill, and Lisa Taylor is here as her substitute, and we've had apologies from Nick Hunt.
Thank you. Agenda item 2 is declarations of interest in matters coming before the meeting. Are there any declarations of interest, please? I'll take that as a no, and we move on to agenda item 3, 1 to 8 on your papers, to approve the minutes of the meeting that we held on the 14th of June. So I'll take them page by page. Page 1, if anybody's got anything they want to say. Richard.
Thank you. As far as I know, Caroline Morrison isn't a councillor, so perhaps if we just amend that. And of course, also to record that she has now left HHCP. Her successor, Keith Spencer, hopefully we can discuss joining the meeting in due course. Thank you.
Thank you. I'll take that opportunity to erase Caroline Morrison as a councillor, and I will say something about that before we move on to the next agenda item. Page 2, page 3, page 4, page 5, 6, 7, and that leaves it all. So that's we're all happy with those. Great, thank you. So before moving on to agenda item 4, I just would like to place on record my thanks to Caroline Morrison, who has worked as a co-chair and done a lot of really excellent work for London Borough of Hillingdon, and I'm disappointed that she's not chairing the meeting today, as it was supposed to be her turn. So I look forward to welcoming the new person whose name has already gone out of my mind.
Keith Spencer. Thank you
very much, Keith Spencer. I look forward to working with him. But our thanks must go to Caroline Morrison, and we wish her all the success that she deserves going forward. Thank you. Agenda item 4, the matters of business in part 1 or in public, and obviously anything in part 2, the recording goes off and we consider those in private. That brings me on to agenda item 5, which is on page 9 to 16 on your papers, and the report is before us, and I'm sure we've all read it. Over to the report officer, Kelly O'Neill, in case you want to make, well, you do, you want to make some very relevant observations, Kelly.
Thank you, Chair. Yes, so I've invited 2 of my public health colleagues who are also going to be presenting with me today, Chika Sharma who is a consultant in public health, and Becky Manville, who is a public health manager. So I will take the document as having been read. So the focus of this document is on population health management. We have spoken about population health management as a enabling framework to really tackle inequalities and tackle really intractable problems, health and social care problems in the past. So what I'm providing today is an update of where we are with the work that we've previously spoken about that has been commissioned by North West London with Optum, that's focused on a place-based project that's really targeting frailty and falls prevention in the borough. I'm also going to pick up another few issues that have sort of been progressing along the way in terms of how population health management is embedded as a tool to help us in other areas. And the two areas that Shika and Becky will be presenting today is some initial focused work on two long-standing public health challenges. The other part I'm going to focus on is, before Caroline left, she presented a really useful discussion paper to the Health Protection Board about how do we enable population health management to become business as usual. And in line with that, there is also, just to flag with the board, some work that's going on at North West London ICB level with the use of NHS England £7.1 million Health Inequalities Fund about how do we make population health management resourcing available across the region, and obviously to think about how do we benefit from that at place level as part of the borough-based partnership. So that's really key. So those are the kind of things that I'm going to pick up today. In terms of the population health management work with Optum, that has progressed really well. It's, as we've mentioned before, it's a very resource-intensive piece of work, and we followed that with a lot of fidelity. We have veered away from the process at one point, because one of the key things that was missing is we didn't do any engagement with residents, and we paused the process for a period of time. And Lisa led a piece of work in order to really, at pace, start to sort of get some insight from residents and people who are the type of people that we want using the services, those types of people that are frail and elderly who are most likely to fall. And actually that has been a real key learning point for us in terms of how do we move our framework forward and present it in a way that provides that intelligence and that insight and make it more meaningful. We're at the stage now is that we finished the sixth and final action learning set. So the action learning set is a forum for the partnership of people working on this project to come together and to go through this very comprehensive program of work. We're now at the really key end of putting the interventions in place. And you'll see at the bullets on the page, at the bottom of page 11 and the top of page 12, the interventions that are being worked up through various responsible officers within the partnership. And by the time that we get to the December meeting, I hope to be able to tell you the progress of those interventions and what that starting point of implementation is leading to. As mentioned, before she left, Caroline presented a paper about what's our approach going to be for population health management. And that discussion paper suggested that we use the Health Protection Board as an oversight board to really think about what's our next projects. And she set out some key recommendations, which included Core 20+5 and various outlying issues, particularly public health issues, where we would want to think about prioritising the use of that framework moving forward. On page 13, just to sort of point out that the framework that was presented was a framework that you've seen before, is based on the King's Fund model, and it's a proportionate framework that allows us to progress a population health management process at speed using the learning that we've taken as part of Optum. On page 14, I sort of mentioned about this £7.1 million that North West London ICB have. That's an investment from NHS England towards enabling population health management across the region. There has been a 3-week consultation with different boroughs across the patch to try and understand how effectively that money could be used to build the capacity and capability across the borough. I haven't heard back what the findings are, but we have from local partners on the board really pushed for taking an approach that best benefits Hillingdon, and I'm sure our colleagues, well, I know that our colleagues across North West London have pushed for similar rather than a more centralised approach, but the outcome of that is yet to be confirmed. And then finally, given that where we are with population health management, and we have just done the one programme at Place, and there is one programme at PCN, at Hayes and Harlington are doing at PCN level, moving forward, obviously this is a really good public health framework. There are a number of areas that Caroline suggested we might want to focus on. So I'm presenting a couple, my colleagues are presenting a couple of initial stages of projects in order to use population health management for some really challenging areas where we haven't made as much progress in terms of improving outcomes as we would have liked. So I'm just going to hand over to Becky first. Becky has shared round a very comprehensive piece of work on health checks outcomes. That is 5 years worth of data, 3 years, 4 years worth of data from GPs practices that have been consolidated into a report, and that has been the framework for some of the data that she is going to present today.
Thank you, Kelly. So just a quick reminder about what the NHS Health Check Programme is. It's the midlife MOT for the 40 to 74-year-olds who don't already have a cardiovascular condition. In Hillingdon, we've got about 83,000 people who are eligible for the programme. So the programme aims to prevent heart disease, strokes, kidney disease, type 2 diabetes and certain types of dementia. People who are eligible for the programme should receive one health check every 5 years. It's a 15 to 20 minute appointment, measures height, weight, waist circumference, blood pressure, and you also have a pulse rhythm check. If you haven't had a recent blood glucose or cholesterol test, you'll have a point of care test during your appointment. You're asked about your alcohol habits, your exercise levels, and your smoking status. Clinical cardiovascular risk score is calculated, and this is explained to the person, and you're given healthy lifestyle advice, and where appropriate you might be referred to a behaviour change service such as stop smoking, weight management or exercise referral. In Hillingdon, health checks are delivered through our GP surgery. We know from the JSNA that early deaths from cardiovascular disease are worse than the England and London averages, and that in recent years what was previously a downward trend has taken an upward turn, which is contrary to the national and regional trends. There are also inequalities in Hillingdon relating to gender and locality. The early death rate for men is nearly 3 times that for women, and that has also increased in recent years. And there are particularly high CVD mortality rates in Townsfield, Useley, Botwell, Barnhill and West Drayton Wall. This slide shows the health and wellbeing strategy priorities and shows where NHS health checks can contribute. By carrying out high quality NHS health checks at scale, we will identify more people with undiagnosed CVD at an earlier stage. More people who are at higher risk of developing CVD can be supported to prevent or delay the onset of CVD. More people with low level risk can receive advice and information, and the people most at risk of CVD can be prioritised. The more NHS health checks we do, the greater the impact we can have on priorities 2 and 3. Just the population health management approach framework we are using. This table here shows the latest Hillingdon performance against the public health outcome framework indicators that are relevant to the NHS health check programme. From this, we can see that Hillingdon has performed relatively well compared to national averages and also our nearest neighbour averages, but less well when compared to the whole of London. London is currently leading the country in terms of health check delivery. This chart here shows the number of NHS health checks carried out each quarter over the last 4 years. You can clearly see the impact of the COVID pandemic in the centre there. We are recovering, but there is more work to do. The lower dashed line shows 65% uptake, which was our kind of target before the pandemic. So on a per quarter basis, we would need to be doing about 2,700 checks each quarter to hit that. So we're about 1,000 short at the moment. So there's quite a big gap to close. The upper line is the 75% uptake. That was the aspirational target for the programme, and to reach that we would need to be doing almost double of what we're currently doing. So there is a gap there. This slide, this is showing us begin to segment by need, which is the second part of the population health management framework. The chart at the table at the top provides a breakdown of health checks by PCN area, and there's a further breakdown of these data in the paper which shows this information by general practice. There is significant variation both at PCN level and also amongst individual practices. The map on the left shows the number of checks carried out by ward. The greenest areas are where the most checks have been carried out, and the red and dark orange areas are where the fewest checks have been done. The map on the right is the the index of multiple deprivation. The red and orange areas are where the most deprived areas. The green areas are the least deprived. The area highlighted, the areas with the fewest checks are not the most deprived parts of the borough. There is some overlap between the areas with fewer checks and more deprivation. The area I've highlighted there is this area, and it also includes the wards mentioned in the JSNA, Townfield, Botwell and Barnhill, now Woodend, Belmore and Hayes Town. This is an area that could potentially benefit from a targeted intervention to increase the number of health checks carried out. When we've segmented by need, we also looked at who has received an NHS health check. We have broken down the data into 5-year age bands, gender and ethnicity. And though this appears to be broadly reflective of the Hillingdon demographics, for example, there is a greater proportion of checks in the younger age bands and more diversity in the south of the borough, and we need to do further analysis to check that these breakdowns meet individual PCN characteristics, and then where there are gaps we need to investigate these further and work out how we can increase uptake in these populations. This slide has been included to demonstrate the case finding potential for NHS health checks and the number of people who could benefit from behaviour change interventions. These data are based on nearly 20,000 checks carried out over the 4 years between 2018-19 to 2021-22. The top chart presents blood pressure data from health checks. It shows the proportion of people in each PCN area who had high, increased and normal blood pressure readings. Around 4,000 people, 20%, had high blood pressure, and around 11,500, about 58%, had increased or high blood pressure. Health check attendees do not have CVD, so these are all potential new hypertensive patients. The bottom chart shows the proportion of attendees by PCN who were found to be obese, overweight, healthy weight and underweight. Around 5,000, 26% of people were obese, and nearly 13,000 people, 65%, were either obese or overweight. These people could all potentially benefit from weight management and exercise interventions. This continues the previous slide's theme and shows that nearly 800 people, 4% of health check attendees, were found to have a high risk of CVD. So these are nearly 4,000, 20%, had a high or medium risk of CVD. These are people who may require preventative treatment such as the statin and referral to behaviour change services. The lower left chart shows the number of NHS health checks where modifiable risk factors were above the high risk threshold. So modifiable risk factors include high BMIs, high cholesterol, blood pressure, diabetes, smoking, alcohol dependence and physical activity levels. About 10% of people had 3 risk factors at or above a high risk threshold. The chart on the right shows the number of checks where modifiable risk factors were at or above high or increased risk thresholds. So nearly 12,000 people, 60% of people had at least 3 risk factors at or above these high risk thresholds. This shows there are large numbers of people with multiple high and increased risk factors who could benefit from more than one type of behaviour change intervention. We need to think about what resources are available to support these people and whether there is sufficient capacity to manage this demand. So what are we trying to achieve? It's twofold. We need to significantly increase our NHS health check uptake, and we need to improve outcomes for our residents who have had a check. We can increase our uptake by reducing our variation among individual GP practices. We can provide more training, more support for lower performers. We know that PCN-led clinics to supplement local services are working well and contributing to our numbers. We want to improve access to our health checks. Ideally, they would be available in a range of community settings with appointments available at different times of the day and the week. We are going to be engaging with the residents to raise awareness of the health check and seek their feedback on the existing arrangements, engage views on where and when they would like to access the service. We are also exploring the possibility of an outreach service to complement the existing GP practice model. We also want to target our underserved groups, so we need to complete our gap analysis to see where there are gaps in our service, and then we want to engage with these communities to understand why and how, what the issues are, why they're not attending and how these can be addressed. We want to raise the profile of our NHS Health Check programme with more and better marketing. We're working with the comms teams to review and update our comms plan and existing materials. We will be piggybacking on relevant national campaigns to amplify the health check message. For example, 2 weeks ago we were in Botwell Library doing blood pressure checks, and we were also using this as an opportunity to promote our health check programme. In the medium to long term, we need to embrace digital technology. There is a digital health check offer currently being developed by NHS Digital. This should be ready in about 2 years' time. Once it is available, it is expected that the age range of the programme will expand to include the 30 to 39-year-old groups. That's potentially another 48,000 residents who will require a health check every 5 years. As well as increasing our uptake of health checks, we need to improve our outcomes. The best way to do this is to increase referrals to an uptake of preventative interventions, to our stop smoking programme, our weight management and exercise services. We also need to target high-risk groups, those who are most likely to benefit from having a health check. And this is just a timeline for action linked to the Population Health Management Framework. So over the next couple of months we'll be completing the gap analysis work, engaging with residents and designing interventions to address the gaps in service and attendance with a view to implementing these in the new year. Health checks are a fantastic opportunity to begin speaking to people about their health and well-being, and we really must make the most of it.
Thank you, Becky, very much. Do you mind just turning your mic off? Thank you. Yes, I mean, some of those figures are quite shocking, I think. You know, large parts of the borough where people have quite difficult situations there, and I suppose what I'm struck with is the digital information you said about the 2 years to get that going. Well, that's just unacceptable, isn't it? I mean, I know it's easy for me to say, but we really can't wait 2 years, can we? We need to get to grips with this now, the disparity and what's going on, and how, you know, people not have, I mean, I know from personal experience, I've never been called in for a health check. I had to ask for one. So I'm not quite sure what's going on. I can only speak from my own personal experience, but coming into a new GP surgery, nobody's even bothered calling me in. Yes, there's an awful lot of work to do here to help our residents become healthier and live better, longer lives. And what concerns me is the Botwell, West Drayton, Hayes area of the borough that clearly is struggling to get a better standard of living. Has anybody got any questions or observations for Becky?
Sorry. So, not always dangerous asking this sort of question with so many clever people in a room, but I'm going to ask it. So, is there a correlation between the when you look at the range of take-up of health checks, is there a direct correlation between that we can identify in terms of the differences using some of the indices that we have, whether it's about mortality or comorbidities, whatever it might be, to show that it's actually that checking that makes the difference? Because clearly the checking is one thing, the interventions that you form and the take-up of those interventions is another thing, and then the outcomes that you get from them are another thing. And which isn't to say, so intuitively and intellectually, it's an obvious thing to invest. Anybody would say, well, okay, yeah, obviously you'd want to sort of invest in that. I suppose is there something that does correlate those things to say that is the worthwhile sort of chasing, increasing that number by 5 or 10?
We don't have that data to hand, unfortunately, but there is a programme of work being developed at North West London level looking at WISIC data. They're going to be producing an NHS health check dashboard, which hopefully going forwards will allow us to kind of track this sort of data and hopefully establish what outcomes are being determined by the programme. So that work is in the pipeline.
Councillor O'Brien? Did you want to have hand up? I know. I thought you were first.
Oh, sorry, I thought you were going to come back to that question.
Do you want to go, Professor Good?
So, in answer to Tony's, well, partly in answer to Tony's question, he won't be surprised to hear this is a very complex area. And when we think about Bothwell and Talfield, those, the 52 years ago, a chap called Julian Tudor-Hart, who's a GP in Wales, termed the phrase the inverse care law. And basically what that means is the people who need care most get it least. And this is what we're seeing. So I suppose in answer to your worries about a digital solution, that's not going to make a great difference. These people are not going to respond to a digital solution. Where there is evidence is where we have individuals or volunteers who go out to a population and actually work with them to understand about health and healthy lifestyles. And in fact, there is a project in northwest London which I'm trying to see whether we can get an introduction in Hillingdon that's being run by a doctor in Imperial who worked 5 years in Brazil by doing this project. And it's being used in Westminster, so I've invited him to come to Hillingdon to see whether we can use the COVID Champion scheme, who are now sort of thinking that they may be made sort of redundant, to actually see whether that's a process we can use there. But it's complex. In actual fact, GPs have been doing health checks since the days of Ken Clarke, when he was Secretary of State for Health. They don't make a huge difference because it's the people who don't need them tend to turn up for them, and the people who do need them tend not to, and that's where the hard yards have to be done, and that's where it's difficult.
Thank you, that's most helpful. Thank you.
good point, and I mean that's something we can flag at training. Is to, you know, when you're welcoming people into the room, make sure they know what they're here for. So yeah, we can pick that one up.
Thank you. Yeah, just interesting. It shows that I went to the GPs the other day just for something sort of not related to the stall, and ended up being sort of have things wrapped around me, prodded, poked, this, stand on those, and before I knew it, I'd had a whole full, yeah, which was great. So it took me by surprise. Didn't know what was. I thought I'd gone into the wrong building. But the I suppose just interesting the point about what the focus is and what draws people to be taking more interest. Is we've spoken before about the sort of wider notion of health literacy, and I suppose just to extend it a little more into almost kind of, you know, system and civic literacy. It's almost what, you know, the things that are there to support people, that rather than, because I'd be interested to know, and I'd be staggered if it were the case that people were taking an active choice not to get a health check. It's rather more the awareness of what it is, what it means, and so on and so forth. And again, and I think now we've got sort of Kelly, and we're becoming a bit more focused and clear about how we're thinking about sort of targeting the areas that have hitherto been sort of out there, and we've touched them from time to time, but not been terribly strategic about it. I wonder whether there is a sort of step back point as to whether the idea of thinking about how we sort of communicate and engage, possibly using the COVID champions or whatever, in terms of that kind of wider system literacy point, in order that people then sort of understand a range of things, not just about sort of NHS, because there's a range of services that local authority has where people just have no idea that they're there until somebody either makes them have it, or gives them a leaflet on it, or gives them some information about it. So just a thought. Really.
Kelly?
I think what we're talking about is a really good example of how we're kind of a guiding coalition of people with different perspectives and different experiences, that if we brought that and consolidated that together, we could think about ways to improve the way that we, for want of going back to the Health and Wellbeing Board, the way that we enable access to, experience of and benefit from the services that we provide. So I think that's really key. I think from what Becky has presented today, 35% of those eligible for a health check have not attended, whether they know it or not, because it may well be that there's been a kind of slightly slippery, will weigh somebody and do that at the same time as somebody else. So increasing uptake and really targeting that 35%, particularly in that oval area that Becky highlighted. And that's the nature of identifying a cohort that we can target and trying different approaches, including having conversations with them about their understanding of why it's important, and why identifying early, that preventing and intervening early when people are at risk of long-term conditions is really key. And it's not just key for us as a system, because prevention is better and more affordable than cure, but on top of that, the quality of somebody's life deteriorates quite rapidly as soon as they start developing long-term conditions, and we know that. So the population health management approach that we want to take with health checks is twofold. One, increase uptake, particularly amongst more deprived communities, because they are the communities that are often more difficult to reach, but we don't try hard enough to reach them. They're also the communities that are more likely to have long-term conditions and poorer health outcomes. And the second outcome that we want to achieve is the so what. So you take these health checks, and if people don't understand they're having a health check, where do they take the information about what element of risk they have, and where do they go and mitigate that risk? What are we supporting them into achieving in terms of the next start? Because identifying something, this is a screening program, and if we kind of look at sort of the screening criteria, there's something quite immoral about doing a screening test, giving somebody a degree of risk, and then just that's it. We have to enable the so what to happen. How do we support people into services that help them reduce that health risk going forward? So this is a really key piece of work, and you know, really welcome the Health and Wellbeing Board to support this as a kind of a partnership approach.
Thank you. Are there any more observations? because I think that you summed it up perfectly, really. That this is a great piece of work, and it's the opportunity to do something with it. And I would ask for regular updates coming back to the board, so we can see that the work that is showcased here, and the timeline for action, that we're actually cracking on with that. So if we can have that timetable back in, maybe next time is a bit too soon, but I'll be guided by Kelly as to when we have that come back onto the papers. But thank you, Becky, for giving an honest feedback of how things are. Do we move on to the next part of it? Oh, excuse me, I'm only looking one way. Please accept my apologies, Dr. Bassani.
No, I think Becky's mentioned it. It's going out to people who do not come in, because as we've seen in GP surgeries, it's the people who are really worried about their health. They access these NHS health checks. And what we found is with doing a lot of these community events, when we've gone out to people, that's when we engage, and people who are reluctant, when they see others having that health check, do engage in that conversation. So I think that's what we really need to concentrate on and do more of, and using the champions to propagate that message across and engage more people. I think that's the only way, otherwise your numbers are not going to change dramatically. Thank you.
Thank you. Are we going to hear about obesity?
Thank you, Chair. So, on obesity, what we are proposing to do is rethinking our whole approach. And the reason for that is that not only we are seeing an increase in trends within adult and childhood obesity, which has been a significant concern, but there are also increasing inequalities gap amongst obesity rates in most deprived and least deprived population. And this results into long-term illnesses and hospital admissions, because we know that nationally hospital admissions are up to 2.4% higher in areas with more deprivation, because obesity is significantly associated with deprivation. So that map that Becky showed about IMD, Index of Multiple Deprivation, it overlaps quite seamlessly when you put map of adult and childhood obesity prevalence. It is strongly associated in those areas to high rates. So what we are proposing is to take a pause and understand. We've been working on this area for several years, but we want to know what our current achievements and gains are. What's the impact that we've achieved, what we've learned from it, and we want to do this by mapping the current offer. There are several initiatives, but we want to understand what resources are being deployed and what are the participation levels, what's the uptake and what are the outcomes achieved. We want to do this with our stakeholders. We want to bring together data, intelligence, and develop insights by working with the communities as well, and understand especially the areas of prevention that are not getting as much of an uptake as we would like to. And I will talk a little bit more about that. But we are proposing to work on areas of national strategy and regional strategy, and get partners together to work around these topics and review what's currently happening. And the reason we believe why we are in this position. In fact, a number of boroughs are in the same situation. So the left of this slide depicts the current situation. So the good news is that local partners acknowledge and understand that obesity is a significant issue. And there are initiatives and interventions applied, and people have significantly comfortable, collaborative discussions across the system, but there are gaps. Whereas the whole systems approach to the right, the whole systems approach brings everybody together, and by working together and sharing common aims and objectives, developing and targeting approaches towards specific populations, and identifying where you want to get to, being ambitious, you can, and the graph at the bottom shows that the evidence shows that you can tackle obesity rates. And there is evidence from Europe, from America, on taking a system-based approach. However, working across the systems, it takes adopting certain mindsets and behaviors. So it's about agreeing to work on environment. So it's not just about targeting individuals and lecturing them about behavior change without looking into their environment, their circumstances, because we know that obesity isn't all about diet and physical activity. It's about the conditions people live in. It's a complex web of actions, complex web of circumstances which lead to a person being obese. It's the food environment, the opportunities around them to be physically active, their lifestyle, their workplace, and the expectations, whether they are doing a sedentary job or they are in a job which requires more physical activity. So it's a set of behaviors that the partners across the system need to adopt in order to work together. And I think this is quite important. It's quite important that partners understand what a whole system approach will expect from them. So as I said earlier, this is just listing those things. I think one of the things I would highlight here is to tackle obesity, even at individual level, it requires people to identify. So one of the things we are proposing is that while even within the whole systems approach, we take a population management methodology and apply to this, as Kelly has said earlier. And in order to do that, we should be treating obesity almost as a chronic condition, where we identify people who are suffering from obesity. We look at the risk factors for them and go upstream and tackle and remove some of the barriers for these people. But in order for frontline, and I'm talking about healthcare, social care, leisure services, in order for frontline staff to do that, they need to be confident about raising the issue of weight. And that's not simple. I think people need to be trained, they need to be empowered to raise the issue of weight with people, and then have sufficient knowledge about services and initiatives to signpost people to. So it requires frontline staff to be prepared. It requires engagement with residents. We know that Hillingdon has some of the best parks and green spaces in the country, but those are not being used for exercise. We have offer of an array of physical activity options, but we don't collect sufficient data about who is attending those, who are the people who are not attending physical activity offer, who are not, because physical activity rates across the borough have been persistently low. How do we motivate people to uptake those interventions? In order to do that, we need to pinpoint and see who are the users, who are the non-users, and then move on to have an approach which is called health in all places, which makes tackling obesity everybody's responsibility, because it's a societal issue, and it will not be tackled and reduced by any single organization or agency. This slide has notes underneath which do talk about what does the evidence say. So National Institute for Health and Care has identified several areas which work and which don't work. I won't go through the whole of this slide here, but it's things like looking at when we talk to people about healthy eating, looking at what area they live in, what's the availability like, do they have information, do they have skills. So it's looking at a whole range of factors, and in order to implement interventions along those areas, we need to know what works, what doesn't work. So NIHR and there is a lot of evidence in addition to what NIHR have put together. However, I think what hasn't been happening is monitoring of once we apply interventions and looking at the impact. I think that's something that we want to look at now that we want to embark on this piece of work. This slide shows the data indicators for Hillingdon. It doesn't include all the indicators, and I'm not going to focus on everything. But as I said earlier, the rates for adults and children are increasing. Just this year alone, we've noticed that as an impact of pandemic, the percentage point increase in the gap among the children living in least deprived population and most deprived population has gone up by about 13 percentage point, and that's the national data. There are gaps in our local data because of COVID. We could not complete measurements for children, so we can't. It's not comparable. However, looking at those who were measured, we can tell that obesity rates have gone up, and it is quite plausible that they would have gone up more in the more deprived areas that Becky highlighted in her slides. Another thing I would like to highlight here is that the preventative initiatives have not worked well, which I've said earlier. So the physical activity rates aren't high compared to national and regional averages. They've been quite poor for adults as well as children. So the percentage of physically inactive adults is high, and percentage of physically active adults is low. So again, this is physical activity data in detail. We have looked at physically data in detail because we have a leisure and sports team. One thing that we are not looking at much is food, and there is ample evidence in Hillingdon about indicators going in wrong direction with respect to food as well. So if I flashed another slide with showing 5 a day uptake, so that's quite poor for adults as well as children. Children's teeth are bad, and that shows uptake of high sugary drinks and foods from a very early age. And also the level of underweight is high and has been persistently high in Hillingdon. So that points to work which should be done around diet and nutrition as well. So I have embedded slides in some of the slides just to show you the work that has been going on. So partners have been carrying on work on evaluating the current initiatives. So here I would just like to highlight that the evaluation so far, they highlight that there is a need to improve data collection on users, non-users of service, and also increase engagement with the residents to find out what are the reasons. This is the population health management model, which you have seen. So the only thing I would like to say here is that we propose that we apply population health management methodology to shift from just treating obesity as an individual choice to accepting that it's more of a chronic disease and it is best managed by early intervention, prevention, education and engagement model, and to improve outcomes and improve value in health and care system, we should use this methodology. And we do this by working with our stakeholders and residents. We are proposing to have some workshops across the borough, targeting areas and communities where obesity rates are high and inequalities are high. And I would say, you know, it's those areas highlighted earlier. So there are parts of Hayfield, there are pockets in Hayes and Harlington, and there are pockets in West Drayton and Useley. So it's working across those areas, but we can also select PCNs or a set of schools. So this is an example of the approach applied at a neighborhood PCN level, where in the planned place, we base approach to physical activity of food and identify the priorities across that particular area. The ask from Health and Wellbeing Board is to provide leadership at place to implement whole systems approach through using population health management as model, but all systems working together. So it's identifying that this is a systems issue which can only be resolved by the whole system working together. And for partners to agree the support of stakeholder professionals who will be engaged in the PHM process and allow us in the public health team to carry out PHM process on obesity. And by December we'll come back and report to this board. Thank you very much.
Thank you, Sheikha. Very informative. Any observations or questions, Sheikha? Tony?
Probably to be a slightly controversial risk, I'm not going to look at Kelly because she might throw something at me. But I think sort of contrary to my youthful looks, I've been doing this for some time, and I'd be interested to know how much is different from 5 years ago, 10 years ago, in terms of the things that we should be doing in order to get to the outcomes, which I'm sort of I suppose I'm saying to us as a system, really, rather than back to Chica or... and, you know, and I know I've had discussions with sort of other people about, you know, whether we talk to, you know, other sectors outside of this room, you know, so around the, you know, the drinks industry, or I don't know, whatever it might be, in order that we sort of look at sort of tackling things from a more sort of a different systemic point of view. Because I guess it's sort of doing more of the same thing that we've been doing for all of the years that I've been doing it, for the sort of minuscule sort of difference that there is. I know it seems slightly defeatist to then say, "Oh, don't bother then." I'm not suggesting that don't bother then. I suppose I'm just sort of being provocative back to ourselves, really, about sort of how and what is it that we do then that is different, because all of the things that we've heard and seen are perfectly logical and sensible things to do, but...
Kelly?
So in response, Tony, I will challenge back and say, in the words of the great philosopher Eric Morecambe, all the right notes, all the right pieces, not necessarily in the right place. So actually this kind of whole system approach is about recognising that it's not just about what we eat and how much physical activity, it's the infrastructure, it's the environment we live in that contributes to all of that. And actually, we've got all the pieces, because actually, working in public health, I've now got the physical activity team working with me. Brilliant. That's two pieces. That's public health and physical activity, and we commission services. Working in the council, colleagues in the council are enablers, because we deal with planning, we deal with roads, we deal with infrastructure, we deal with housing development. All of that can be enabled. But it's and in terms of the NHS, you know, there's commission services, there's general practices, goes back to health literacy, working with schools. What we just need to do is put it all together so we create a whole system picture that enables all of that to be more effective. So what we're saying is it's not different from what you were doing 5 years ago, but we're fragmented. We're just really, really fragmented. If we were to bring this all together in a really comprehensive way and really understand the drivers, looking at place, not just at borough level, but let's think about, I mean, Chica sort of mentioned Hayes, where that's the area with the biggest challenge. If we look, and one of the things that we didn't show is embedded in this presentation is an assets review at place level, is looking at the services that we commission, is understanding the data. Now this is the early stages. Once we start bringing that together and we focus on perhaps an initial focus on Hayes or any kind of place, it doesn't really matter. When you start bringing that together, talking to communities, look at the assets that we currently have, look at the way that the council works in that environment, the way the NHS works in that environment, it's a compelling bringing together of different minds and attitudes of all the things that we actually do to get a bit better outcome. Because, you know, we can't keep doing the same things over and over again and expecting a different result. Although I hasten to add, every time I say that, society shifts around us. So sometimes doing things over and over again change the result because society changes. But I don't think we should be planning for that. But what we do have is the capability and the infrastructure and the enabling parts of the system. Bringing that together could deliver this. But we need that bringing together thing to be key. Is that challenge back?
It is. I'll shrink back into my chair.
Thank you. Sandra, did you wish to... Yeah.
It was the same point as Kelly's, but nowhere near as eloquently put as that. But the first discussion we had from Becky is the same whole system point about bringing everything together and joint working approach, specifically targeting and using that model, which is being done in the Hayes and Harlington PCN areas, working together as a system to take this forward will make a difference.
Any other observations? Lisa and then Kevin.
Thank you. Obviously, having worked with Kelly and the team on some of the other public health management priorities, I just wanted to say that I'm very pleased to see that community engagement is one of the priorities within this. And I think that certainly talking to the communities to identify those barriers
will be probably the key sort of part of this, which will enable sort of bringing those systems together and perhaps just rethinking that approach entirely. I'm particularly sort of concerned about those that, you know, with the cost of living crisis that we're about to face, that quite often for many families in deprived areas, you know, it's cheaper to buy a bucket of fried chicken than it is to go and buy some healthy fruit and vegetables. So I think that's a really important part of this.
Kevin?
I wasn't going to say anything actually, but I will do because you've invited me in, so I want to. It's just that as someone that was invited to look at this subject going back a few years now, and having brought previous reports to this board, what we were able to do hitherto was to capture really quite well what was already going on, to map that out, and then to sort of nudge it slightly in different directions across partners, and looking at programs like the My Choice program and other things that we've done, and to identify one or two gaps. We filled those gaps. But what I think has been missing, which we've now got a proposal to try and address, is that much more strategic oversight of it all, and to actually bring that together with a more concerted effort. I think it's really quite frustrating sometimes when you've just got a process that just allows you to sort of capture it and push it a little bit, rather than really have a drive that will make the difference that's really needed. And I think that's the problem we've had so far, in that there's a lot of worthy and validated projects out there, but collectively they haven't really hung together as a cohesive programme enough.
Tony? Oh, sorry, Kelly. Sort it out between the two of you. Who goes first?
Thank you. Actually, not to look like it is just Kelly and I having a sort of fencing match on the side of the table, but following a discussion with Sandra earlier about sort of related points, Kelly's made a really good point, which is that I think there is something about how we do position public health better in the local authority. So I'm going to start and say you don't know this yet, Kelly. So I'd mentioned to Sandra this morning that we kind of put together a programme that starts with, I think, getting CMT, so that's the corporate management team of senior officers of the council, sort of onto the programme really, of kind of sort of understanding why, making the connections that sort of Kelly articulated in putting me in my place. But then also we have a senior managers conference which is fortnightly, so that's all of the next tier, so it's quite a broad range of people that work across housing, planning, roads maintenance, you name it, all of the different aspects of things that we do, again in order to get and understand that point. And I'll share an anecdote with you. I went to visit our depot on Hillingdon Road a couple of weeks ago, and so that's sort of what it sounds like. It's a depot with wide range of services, that are resident-facing services that are delivered from there, sort of grass cutting, bin collections, you name it. And I spoke with the housing maintenance chap down there, and actually just in explaining what he does, it just identified a whole range of public health related factors and matters, and in fact related to the first one around falls even as well. So actually we do need to, I think, as a local authority, so I'll own and take responsibility for this, we do need to do some positioning, because I don't think we ever have really. I think we've just sort of had public health there that's sort of, you know, done things in the background and done things it should have done, whereas I think we need to probably have it a little bit more centre stage, put the spotlight on Kelly, and sort of have the opportunity to get it sort of more firmly embedded in understanding. And then obviously I'll talk to sort of cabinet colleagues about that similar sort of discussion amongst cabinet members in considering papers and things that come through, that the implications of the public health sort of dimensions of that are considered. So, thank you.
It's your go. I think it's probably about 30-15 to Tony at the moment.
No, I'm winning this one, I can tell you. I can start by saying that the Executive Director of Adult Services and Health has already advised me that she is that efficient, so I do know of that, and that's brilliant news. I just want to manage expectations here, because but being a transformation project does not mean this is going to change a week on Tuesday. This is a medium to long-term transformation program. We're probably not going to get anything happening this month or next month, we're probably looking at 18 months. But the sooner we start, the better. On top of that, just for you, Chair, and Councillor O'Brien, there are some policy decisions that enable us to do this more effectively, some of which will have been, no doubt, have sort of be presented to you previously. Things such as sort of addendums to fast food planning, etc., etc. So there are some decisions that will help us, but we know that those decisions may not be in the interest of the council at certain times, and we do recognise that. So yeah, I just want to manage. The sooner we get this started, the better. It's not short term, it's transformational. It needs all of us as partners to work together on this, because if we can get this we'll be a beacon. And going back to one of Sheikha's earlier slides, being really ambitious and really creating a narrative and some outcomes and putting Hillingdon on a map that works together as a whole system will really be something quite spectacular and special.
Thank you. Professor Goodwin?
So there's a lot of energy being generated by this, a lot of enthusiasm, which I think is very, very good and proper. Although you have to be a bit sceptical, because if it was that easy, it would have been done much earlier. This isn't a new problem. And as Sheikha said, we really need to gather the evidence to what's effective, because clearly we've done things in the past, and as Kevin has said, some things have worked, but we got quite low rates of physical activity, looking at the data, even though we've tried to do something. So a couple of things I think we need to be aware of. One is there are lots of areas where we can do something. We need to prioritise that. We need to make sure what's going to be the most effective, what's going to be the biggest sort of gain for our pound of rates and NHS money. And also we've got to be very sophisticated and robust in our evaluation of actually what we're doing and how well we're doing it. And it may be that we've actually got, on our doorstep, got the Health Economics Research Group at Brunel, who actually have an expertise at evaluating these the health interventions, and possibly supporting us in saying which things we should be doing and how we should actually look at evaluating them.
Very good point. We've got quite a long agenda, so unless there's anything that anybody else, I keep missing you out, don't I? I'm sorry. It's Councillor O'Brien. Please accept my apologies. Carry on.
So, Councillor O'Brien, it's significant investment, and I think going back to being ambitious, one of the things that over the last, predated me, to be honest, I can't really take any credit, that there is some dedicated leads who have worked together to really sort of put in place very ambitious plans, and they have, well, we have now promoted those plans to London councils, to the LGA, and once you start developing the ambition, so comes the funding. So the funding's not from the council; it's from various other routes. And once that funding started to come, then so followed other funding. As long as you can demonstrate impact and outcomes, because actually, I mean, the infrastructure in Hounslow is pretty similar to the infrastructure here. I think you've got better parks than we have than there is in Hounslow. But actually, it is work in progress to align all of that whole system approach. And Hounslow's not there, that's still probably about a year, 2 years off. but actually there's a kind of a strategic intention actually to achieve that. And I think we've got that here. We just, as I say, we just need to just make sure it's all brought together in a way that everyone understands, everyone signed up to and committed to deliver against.
So, I think hopefully we've got the whole support of the board now to agree the recommendations that we've got on page 9, and essentially some of them are summed up on there, but it is very much about this whole systems approach. So we look forward, unless anyone's disagreeing, we look forward to cracking on with the work and seeing a healthier population within our borough. And no pressure, Davis, over there, no pressure. Thank you very much, Kelly, Sheikha and Becky. Turning my mic off. Moving on now then to agenda item 6, which is the Integrated Health and Care Performance Report, pages 17 to 30 on our agenda. Gary, please.
Thank you, Chairman. Just a few points to highlight really before Chairman, you open it up to the board for discussion. Starting off with the good news story, the crisis house that has been the subject of numerous discussions at board meetings over the last few years has now opened, and people have actually moved in. Next point is I do actually have, I understand from Vanessa that there is actually more information about developments with the Hillingdon Cove Cafe. So what I suggest, Chairman, is I get that information and actually circulate that to the board outside of the meeting if the board's happy with that. You'll notice that the board does actually make reference to what would have been item, or what is item 7 on the agenda, the 2022-23 BCF submission report. And unfortunately, there have been some changes to hospital discharge funding arrangements, which we're currently working through with partners, which has meant it's not possible to complete that report in time for the board's agenda, but I'll come on to that in the implications of that in the next item. The other point I did really want to highlight was about the post-April 2023 BCF arrangements. The expectation at the moment is that arrangements for what is likely to be a 2-year plan are unlikely to be published before January 2023. What I'm suggesting in the report is perhaps actually sort of having the dialogue with North West London about trying to pursue some of the ambitions that have previously been discussed at the board, such as the development of the place-based health and care budget at an earlier stage, partly because of one of the issues that I think we find is once we've actually got the planning requirements published, we have quite a short period of time to turn things around, and what hasn't been agreed by then is actually quite difficult to put in place. So the views of the board on that would actually be helpful. I'll leave it there, Chairman, and happy to take any comments or questions that the board may have around the rest of the contents within the report.
Thank you, Gary. Does anybody want to start? Nobody? Tony?
You now have to fill a gap. But just on the crisis house, have we got? It would be really good to see an ongoing, almost like sort of quarterly, probably, because there's been lots of ifing and butting about this. But just in terms of the different categories of guests, as I understand they like to call them, which is that, so there where there's a real avoidance, for example, whether that be about A&E kind of attendance, whether that's about a mental health acute admission, whatever it might be, actually it would be really helpful in order that when we're having discussions in the next year or the next funding cycle or whatever that's going to be, that we've got some evidence, because we do know the evidence that was put together in order to have it as a business case in the first place sort of clearly stacked up in the other areas that we looked at. So I would hope that they are, but just to make sure that we're getting that information and evidence on a quarterly basis, because it may be that we need to alter criteria, change things, and I wouldn't want to wait until we get to the end of the year and then look back and think, oh well, we could have done this or we could have done that. I think the sooner that we can get onto it, the better. Thanks.
Anybody else have any comments or observations? Is there anything else you want to say, Gary?
It's just the point really about the dialogue with North West London, about actually taking that forward in respect of the previously discussed ambitions, particularly the health and care place-based health and care budget.
I think that's probably there's a part two that we might want to
Leave it till then, is that what you're suggesting? We'll do that. Thank you. I mean, there's some really good evidence of really some good stuff going on here, and I will be interested to see the Cove Cafe report if we can have that at the earliest, because I'm interested in the publicity campaign, and so hopefully there'll be some positive news coming out of that. Thank you. Unless there's anything that we want to say, I'll move on then to the next agenda item, which is 8, 31 to 208 on your... Oh no, I've missed 7. Sorry, recovered myself just in time. Agenda item 7 to follow. Better Care Plan Fund.
Chairman, as I said a moment ago, unfortunately due to circumstances, it hasn't been possible to bring the report to the board within the timescale. What I would ask is if the board would agree to delegated arrangements to approve the plan and any amendments that may arise from the assurance process with NHS England. This is something that is not uncommon. We've done this on several occasions. So the suggestion, Chairman, with the board's permission, is to delegate to the Executive Director, Adult Services and Health, to formally approve the submission documentation on behalf of the board in consultation with yourself, the Joint Borough Director for for NHS North West London, and the Chairman of Health Watch Hillingdon.
Is everybody in agreement with that? Makes sense, doesn't it? That's the way we do it. That's the way we'll do it. Thank you.
Thank you, Chairman.
I can now move on to the agenda item that I was going to move on to before I realised I'd made a mistake. Let's do number 8, the Pharmaceutical Needs Assessment update, please.
Thank you, Chair. This is just a brief update. So, colleagues will recall I presented the draft P&A back in June, and that was ready for consultation. That consultation did proceed. It covered the period 21st of June to the 19th of August. That went out online. We had separate correspondence that was sent to partners. That included the partners in the health sector, the local pharmaceutical committee, and also Health Watch. And that correspondence went out on the 21st of June, and a reminder was sent out on the 26th of July. Obviously, this is quite a niche topic to be seeking comments on. We didn't get a huge number of comments. There were a couple that we received from local pharmacists. One of the responses agreed with the consultation and the questions and the findings from the P&A. There was another response from a Boots pharmacist who was querying opening hours, and we've amended those in the P&A. We had one feedback from a local resident, which I know, Councillor Bryan, you were also copied into. There was the issues that were being raised were quite specific, and I think touched on the wider provision of health services within that part of our borough. So kind of superseded some of the topics specific to the P&A. And then there was feedback that we'd requested from NHS England, and that was received last Monday. And that there were about sort of 10 issues that were raised, some of which touched on terminology that was being used, so what is enhanced, etc. Also questioning why we'd chosen the localities, the geographies that we were working on, and we will go back and incorporate any of the comments where appropriate and provide feedback back to NHS London where we feel that the P&A adequately addresses it as it is. What we're looking for in terms of recommendations is delegated authority, because we need to get the P&A published by the 1st of October. So if I could get delegated authority to myself working with the DPH to finalise the document before it's published, that would allow us to kind of hit that statutory time frame. I'm happy to take any questions.
Thank you. I mean, this is a really comprehensive piece of work, Naveed, so thank you very much for that. Are there any observations or questions for Naveed?
Just to start by saying my usual thank you for being so committed to this, and once we get it published I'll buy you a sugar-free drink to celebrate that. I think these are very, very challenging processes, and actually having looked at the document, and I've read it now 3 times, it's a really comprehensive piece of work that really does set out what the needs are within the borough. And I think there has been sufficient time and energy to focus on consultation. People have submitted some comments that perhaps tweak the document rather than change it particularly. So I think as long as we incorporate those, and I think it's a comprehensive piece of work, and for me, having read it, it does what it needs to do.
Professor Goodman?
So, in primary care, there's been the development of the primary care networks. The primary care networks have been funded to employ community pharmacists themselves, and what we're finding is actually they're now in great demand and short supply. And I wondered whether you'd asked any questions within the pharmaceutical needs assessment about future plans for workforce planning.
I will get back to you on that one.
Any more questions or observations? Are we all happy to agree the recommendations on the page in front of us? Is that a yes? Thank you very much. Next agenda item. I need my glasses on today. Agenda item 9. Okay, so I understand that we are missing somebody who has sent his apologies. Is anybody else able to talk to that particular agenda item, or shall I just put it off until next time? Richard?
Sorry, Chairman, are we mentioning item 9 or item 10?
My fault, because I'm sharing it not very well. Apologies, Richard. You can talk about it if you like, but Sandra's let's all swap around. Sorry, Sandra, please carry on.
It's absolutely fine. It's a very brief verbal update today on the adult social care funding reforms, which came into place earlier this year, and we are in the process now of working through with all of the social care providers in care homes for those 65 plus, age 65 plus, and in domiciliary care aged 18 plus around the fair cost of care for the services that they're delivering, section 1 of the social care charging reforms. Section 2 of that is the financial assessment process that we need to be addressing, so that how we actually are ensuring people are eligible and how they are charged for their care and the processes that they undertake, and where in fact the eligibility and threshold for financial assessment kicks in. And then section 3, the care cap, which comes into place in October 23. We need to be prepared and ready with a market position statement on the cost of care by October, so October the 23rd this year. We will have a draft position statement shortly, which is a combination of information about all of the costs associated with the provision of care by those providers, as I mentioned, which will then indicate what the council is likely to assess as a fair cost to be purchasing both care home placements and domiciliary care going forward, which obviously then triggers an impact on what residents will be required to pay for their care if they're eligible. The eligibility thresholds have moved, which means those previously with savings below 23,500 would be charged, but not until they reached a threshold earlier than that. The new threshold is over 23,000, but up to 100,000. So it gives us a much wider span where people will be eligible to be for some support with their care. So councils will be undertaking assessments for residents going forward from February 2023, and the care cap for those eligible will start to be in place from October 23, where people can calculate the cost of their care up to £86,500. So far, the next steps for us is waiting for the draft market position statement, and we'll come back to the board next time with an update.
Thank you very much. Anybody wish to say anything? It's worth waiting for, Sandra.
I would just add that it's quite an impact on local authorities, and isn't just a local authority issue, it's a wider system issue in terms of the demand and increase in people coming to the local authority for care will put on the system, so it's important that the whole system approach is considered.
We are well prepared.
We're getting prepared in advance for the impact will start to hit us from February next year, and we need to make it a smooth and reliable transition for residents to be able to come to us if they want to, but at the same time we need to be able to manage that demand carefully.
Thank you. Anybody else? Next agenda item is 10, I believe, unless I'm wrong again. It's 10, isn't it? Let's just all smile at me. Thank you. Okay, so that is the ICS strategy, and that is what you're saying, and I think you're going to speak, are you, Richard? Thank you.
Shall I just say a few words on that, Chair? The North West London ICS Director of Strategy was very keen to attend this board to give his presentation of the progress on strategic development, but unfortunately was unavailable for this meeting, and you may wish to invite him at a later date. But as you would expect, the North West London Integrated Care Board is engaged in developing an integrated care strategy, and is committed to doing that in partnership with all stakeholders, in particular local authorities. A number of workshops have been set up. There's one coming up in October, I believe, Chair, to which I think you've been invited, and I believe other representatives of the local authority, the Director of Public Health, Director of Adult Services, Director of Children's Services, and the Chief Executive as well. And I think, as you would absolutely expect, the integrated care strategy for the 2.5 million population of North West London is fundamentally built on the principles of this Health and Wellbeing Board and the other borough Health and Wellbeing Boards across the patch. The Secretary of State has given integrated care boards 4 objectives, with the first of which is improving outcomes in population health and healthcare, the second, preventing ill health and tackling inequalities in outcomes. I think exactly the topics that we've been discussing this afternoon, and those elements that Gary's report on the integrated healthcare and performance report is measuring at a local level over time. And I think what is also key is that the ways of working that Hillingdon Health and Care Partners have been engaged in over the years, of working across health and social care, across players in health, with general practice, with the voluntary sector, and of course with the local authority, is very much what North West London wants to replicate as a broader system. There are a number of delivery programmes that colleagues will be aware of. I think a total of 9 core programmes, partly looking at the key service programmes, including mental health, including acute care, but also including workforce development, research, and a number of key clinical networks that have been established across North West London, including maternity, children and young people, cancer services, support for people with long-term conditions, and older people and end-of-life care. Again, whether we are working on those at Hillingdon level and therefore representing into North West London, or taking note of the North West London programmes and showing perhaps where Hillingdon has overachieved on some of those, they are, I think, a pretty close match between North West London and localities. So I think please watch the space, please contribute through the workshops and the engagement that North West London wants to do. But I know that we see health and wellbeing boards as fundamental to the development of that strategy, and of course also the implementation and the monitoring of that work.
Thank you very much for that feedback and that report. Any observations on that, or can we move on to 11, which I think is just for noting? Does anybody want to say anything about agenda item 11? I think we've said what we want added on the next boards, Nikki, and I'm sure you've... I know you have. I know. Yeah, so that ends the part, first part of the meeting, part 1. We just need to go into part 2, but we just need to wait a minute for the technology to be turned off. So thank you to anybody that is watching, and we'll see you next time. Thanks.